more time to discuss this? Feel good? Love the response. All right, well, Justin, short that is, in case there's another. Tell me about ALS. Tell me about some clinical symptoms that might be suggestive of ALS.
That would be motor issues as opposed to sensory issues.
Great.
Difficulty with speech or swallowing, depending on where it attacks.
All right. Yeah. That's still motor.
Yes.
Yeah. Does it progress?
Yes.
Yes. Insidious progression. Yeah. Yeah. This should. You have 2 to 5 years after diagnosis. That's pretty quick. Yeah. Okay. So rapid progression of motor symptoms. So you mentioned difficulty speaking and swallowing. If those are one of the initial symptoms, does that suggest a better or worse? Oh, there you go. Okay, great. Okay, thank you. Start a little bit. Jess or Jessica, Herbert, either one. Upper and lower motor neuron weakness. Where's Jessica at? I don't know all my names. I'm so sorry.
Okay.
I'm an idiot. All right. Jess. You prefer Jess or Jessica? You wrote them both. So you want me to say both?
Sure.
Okay. Jessica, upper and lower motor neuron weakness. What's the difference?
Upper motor neuron lesions disinhibit spinal reflex.
Disinhibits? Fantastic. Yeah,
Okay.
exactly. What does that mean? So that we all understand that, because that doesn't make any sense to me. Disinhibit.
Isn't that related to the flaccid paralysis? Or is not?
It'll follow that. Yeah, yeah. So you might see flaccid paralysis if you have marked loss of upper motor neurons, like in a spinal cord injury, for example. So if you lose a bunch.
And they have like hyperreflexia.
There we go. That's what it is. That's what that disinhibition means. So your reflexes are much more robust, and you might see abnormal reflexes occur. Do we see that in lower motor neuron damage?
Yeah.
What do we see?
It's an impaired communication with muscles, so they have like decreased tone and hyporeflexia and the circulation.
Yeah. Yeah. Those uncontrolled spasms. Yeah. So both of them are going to produce weakness, but they do it in different ways. Right? If you get rid of the upper motor neuron, because these normally inhibit spinal reflexes, like you said, you see hyperreflexia and increased muscle tone, because we're no longer controlling the communication with our lower motor neurons. If we lose our lower motor neurons, no more innervation of the muscle. So instead we see a reduction in reflexes. You can't initiate contraction without a motor neuron. Is that clear to everyone? So when you go testing your reflexes, an increase or a decrease should tell you upper or lower motor neuron damage. Okay. Go back to the RNA basis of cell toxicity. Oh, damn right. All right. We're going to move ahead. Do we need to review this? Or have we reviewed this way too many times already? Loving the responses. All right, we're going to go ahead and move on then to multiple sclerosis. That's today's topic. Kind of sounds like amyotrophic lateral sclerosis, if you only listen to the last word. So they both involve glial scars. That's what the sclerosis is. In this case, we don't see the pronounced muscle wasting and degeneration in motor pathways. Instead, what we see is a more central degeneration, and we see multiple sites. That's the name, multiple sclerosis. We see multiple sclerotic lesions, mostly in the white matter. This is a disease that targets oligodendrocytes, myelinating glia of the central nervous system. And up here, we can see the progression of multiple sclerosis. So the hyper intense kind of light blobs there, those are showing you the glial scars. Really, they're showing you areas of inflammation and increased blood-brain barrier permeability. see that over time they get worse. We also see an enlarging of the ventricles, showing you overall brain atrophy. So we're getting degeneration of the myelinating glia, and we're also getting degeneration of neurons. And when we lose our neurons, that's when the impairments become permanent. We'll start off by talking about the prevalence and the clinical symptoms that you'll see in multiple sclerosis, and then we'll talk about how this disease occurs, so the pathophysiology, and then how we treat it. There are some pretty decent treatments for MS, unlike the other diseases we talked about. They're actually disease modifying in this case, so you can prevent progression. There were some questions. So before we get started, one of the questions is, why are these risk factors seemingly random and so weird? Well, they kind of are, but they're also kind of not. They all kind of center around immune function. So you guys, the birth month, that seems kind of weird, doesn't it? And it varies depending on whether you're in the northern or southern hemisphere. We'll get down to that in a little bit. What about vitamin D deficiency? This is actually related to birth month. Again, we'll get to that in a little bit. And vitamin D regulates how reactive your immune system is. So application of vitamin D is going to decrease the reactivity of T cells. So if you have a vitamin D deficiency, your T cells are more reactive. You're more likely to have an immune response. And that immune response, targeting oligodendrocytes, is what causes MS. Is an oligodendrocyte considered nervous tissue? Yes. It's also supporting tissue in the nervous system. So nervous tissue comprises neurons and glia. Both of those are nervous tissue. Only the neurons are neurons. Glia are glia. But they are all nervous tissue. Okay, back to that month when we're born. Well, if you're in the northern hemisphere like us, then spring babies are more likely to have MS. And that's because the mother was carrying the baby during the winter months. Less sun, more vitamin D. The opposite is true in southern hemispheres. You don't see this relationship at the equator. Daylight's constant. So that's the relationship there, and that takes us back to vitamin D, which takes us to the immune system. I'll get back to the immune system here. That cerebral hypometabolism, that's just telling you that neurodegeneration is on the verge. Your neurons are not long for this world. They require a constant supply of glucose and oxygen, just like in stroke. We talked about that. It's still true. So if you're seeing reduced blood flow, reduced glucose uptake, this is telling you that your neurons are not being well fed. If they're not well fed, they don't make enough ATP, they depolarize. This leads to cell death through either necrosis or apoptosis. That's the implication there, and the degree of cerebral hypometabolism correlates with disease severity. So progression from the relapse remitting to more progressive forms of MS, and also cognitive impairments correlate with the degree of hypometabolism. If you're not feeding your neurons, they're going to die. Okay, the major histocompatibility complex. This is a large collection of proteins that are involved in antigen recognition. So these are cell surface proteins that either mark self, don't kill me, or foreign, kill me and whatever brought this. So if a cell is infected with a virus, it's going to chop up bits of that virus and present these little gifts out to T cells. If they hear something foreign, they'll find it and kill me too, because I've been infected. So that cell's going to die, and then the viruses that display that antigen will also be killed. Mutations in the major histocompatibility complex are associated with at least some cases of MS. Again, it's all about an immune targeting of oligodendrocytes. If your oligodendrocytes appear to be foreign, they're going to get targeted and degraded. That appears to be the case in at least some cases of MS. So yeah, these seem random, but they actually all kind of have something to do with immune function. Vitamin D. Your birth month determines how much vitamin D your mom got. That's going to affect your immune system function. All right. The sensory motor abnormalities that we see in multiple sclerosis are all caused by demyelination. I think I talked about this in lecture 1. maybe lecture 5 as well. I don't know. Look at the notes. I should know this. I'm sorry. So demyelination is still going to impair the conduction of action potentials down the axon. In the short term, we can overcome this by reinserting ion channels. We pay a little more ATP. That's all right as long as we can remyelinate that axon. If we don't, that increased ATP burden is going to lead to overproduction of free radicals and oxidative damage, leading to death of the neuron. Now, the prevalence of MS varies across geographic locations. It varies across age, but it's not the same age dependence that we see for other neurodegenerative disorders. Things don't just get worse as you get older. This is one of those instances where we actually see targeting in middle age here. So here we're looking at the prevalence per 100,000 individuals across a few different years and several different age groups. And you can see here, fairly normal distribution. That's kind of nice. So we can do parametric stats on that. Wrong class, sorry. The max here is going to be in your, not your golden years, those are over here. You're in middle age, so in the 30s, 40s, 50s. Here's where we see the highest instances of MS. There are childhood cases, but they're fairly rare. The prevalence of MS varies in more northern hemispheres and Australia as well, because we're moving further from the equator there. But certainly in these northern hemispheres, where we have periods of reduced daylight, which could lead to then vitamin D deficiency, we see higher prevalence of MS. The coding is right here, so greater than 100 per 100,000, right? Over here too. And these folks, came over here and settled. So there's also apparently a genetic component as well, because if you look across the same latitude, the risk isn't constant. It drops off once we get over here in East Asia. So it's not just latitude. There's also some sort of genetic component. We see about a 3-to-1 male to female ratio. See that in a little bit as well. And then we see these racial differences. Now the racial differences are going to be carried with you as you move. So it's not just your environment, at least in the immediate phase. Let's have a look at these data here. So here we're looking at the prevalence of MS in South Africans, whites in South Africa. Here's all of them, the solid line here. So here's males, females. Notice the higher prevalence in females. And then they're looking at immigrants who just showed up, fresh off the boat. That's this line right here, the highest prevalence, those that came from those very northern latitudes. And then here are white folks who have lived in South Africa for long enough that they speak the native language. They've been there for a long time. Those that are still English speaking, they haven't been there quite as long, but they've been there longer than the new immigrants. Notice the trend. New immigrants live there for a while, live there for a long time. Lowest prevalence, whether you're male or female, it drops down. So where you're born certainly matters. I don't know why this continues over time. It's kind of odd. But the data are the data. We must believe them. So it's a mix of environmental factors, genetic factors. Men and women are genetically different, and different races are genetically different. So it's not just nature or nurture, as in any debate of nature versus nurture. They're both contributing here. What we see in MS patients are multiple sclerotic lesions. Hence the name. You can visualize these with MRI. You should see at least 3. So here we want to see multiple, not 1 or 2. So we want to see more than 3 of these lesions in the white matter. And they need to be large enough to see. So they got to be at least 5 millimeters here. Now these lesions are not static. They might appear and disappear. They might grow. They might shrink. So these will change over time. That's because these lesions are indicative of areas where we have not just tissue damage, but permeabilization of the blood-brain barrier. And the tissue that we're damaging here regenerates. Unlike neurons, you can make new oligodendrocytes. So as the tissue heals, and as the blood-brain barrier permeability is restored, these lesions will go away. Because when you add a contrast agent like we're seeing here, so here we can see a few lesions there, here's a handful down there. That's showing us areas where the contrast agent was able to leave the vasculature. In other words, areas where the blood-brain barrier was permeabilized. When your blood-brain barrier is restored, those contrast agents aren't going to enter again. So this can cause the lesions to disappear. Remyelination and tissue healing will also cause the lesions to disappear. Of course, progression, further tissue damage, and blood-brain barrier permeabilization will cause them to grow, or they might appear in new sites. So these are dynamic. We'll also see gray matter degeneration as well. Initially, the white matter is going to be targeted, but inevitably, we will see the loss of gray matter. Do we know the difference between white and gray matter? Remember this. What's that? Presence of myelin. Which one has myelin? White matter, exactly, because myelin's fat. Fat's white. If you don't believe me, go to the grocery store. Have a look at the meat. So the white matter, that's where we have our oligodendrocytes. In the gray matter, that's where we have our neuron cell bodies, dendrites. That's where we have synapses, for the most part. The loss of myelinating glia will lead to the loss of neurons. And as the disease progresses, we see progressive atrophy in the gray matter. Believe it or not, that's what this is showing us. So these are just a few different views of the brain. Right, we got a couple horizontal sections, parasagittal, and coronal section. Then they're giving you the probability of atrophy. They looked at a large number of MS patients here and tracked their gray matter atrophy over time as their symptoms worsened. So over the course of the disease, which areas were likely to degenerate. The specifics don't matter. Compare here to here. Yellow means 100% probability of atrophy. Notice the widespread degeneration of gray matter. Sure, MS is a disease that targets the white matter, but in doing so, the gray matter is going to die. Those neurons who house their cell bodies here in the gray matter, they're running their axons through the white matter. The white matter degenerates, they have an increased free radical production that leads to their cell death. Yes?
Okay, so lesions do not appear in the gray matter though? Or?
No.
Okay.
No. We'll see the sclerotic lesions in the white matter.
Okay.
And then that will lead to the shrinkage of the gray matter. The more pronounced your gray matter atrophy, the more pronounced your symptoms. Speaking of symptoms, let's have a look at them. This guy's going to tell you a bit about his experience with MS. It's fairly long, so I'm going to go ahead and get it rolling.
All about the symptoms that I started getting that led up to my diagnosis, the things that made me want to get myself checked out by the GP. But what I haven't done is talked about the whole range of symptoms I had prior to that and the way my symptoms developed. So I'm going to go a little bit more in depth into that today. I've already told you about the pains and the tingling that I got. The tingling I got in the feet, the sensation of an electric shock continually going through my feet, the pain and the numbness. But it started much more subtly than that. I was working a full-time job in April of 2012. That came to an end in April. And I started to just feel a bit run down. And I'd been feeling a little run down for a while. And that just increased after I left the job. And it just got worse and worse and worse. But I figured at that time, it's not going to last. It'll be a few weeks. I'll take some time off between jobs. And then when I start to feel better, I'll start applying for other jobs and I'll get myself back to work. This lasted for a few months, and after about four 4 or 5 months, I started to think there might be something more seriously wrong with me. That's when the tingling started, the tingling sensation in the feet. That led to pain in the feet, pain of the leg. Then I started getting cramping. I started to have balance problems. And then I started to get numbness with pain. I started to have pain in the lower part of the leg, and then the numbness started in the groin and worked its way down. So it was like they met in the middle. At one point, I was numb completely from the waist down. My balance started to get even worse at that point. And the time that I kind of really knew there was something severely wrong was when I had to run for a train. I got to the train station on a trip to London. I was on my way back from London, and I had 5 minutes to get from one platform to the other. And I ran along the platform. I got maybe 10 paces, and my legs just stopped working completely, and I just fell on the ground. And it was a struggle to get my legs working again. I also found that I constantly felt like I was wading through water or something thicker than water, like a thick porridge. Just moving myself forward was a constant struggle. I felt like I was fighting against something that was on level ground. I felt like I was going up a very, very steep hill. If I was going up and downhill, that just became even worse. And very, very steep hills I just could not do at all. So walking generally became very problematic for me. I started to get confused very easily. I started to get fatigued very quickly. Any sort of physical activity would just wipe me out. If I worked for an hour, I'd immediately have to sleep for about 2 hours after. That was kind of the general ratio for me. Every hour that I put into work, 2 hours sleep. It got to the point where I'd go and work for a day somewhere. I'd sleep that night, and I'd sleep the entire following day. Also, as I mentioned in the previous video on physiotherapy, I could not concentrate on anything at all. Reading was very difficult, even reading road signs, reading just words, individual words, was very difficult. Whole sentences was virtually impossible. Anything where I had to really concentrate, couldn't do it. My memory also was affected. My short-term memory was virtually non-existent. If you'd asked me what I did yesterday, I'd have no clue. Timelines started to merge into each other. When I could remember things, I couldn't remember whether I was remembering something from yesterday or from 5 weeks ago. It all sort of blurred into one. That was very traumatic, and this led to all of these symptoms combined, I guess, led to me becoming quite depressed. And I didn't realise I was suffering from depression, because stuff that happens to me, I can kind of laugh it off, shrug it off, and joke about it. So I wasn't really aware that internally there was a lot more going on until I actually was told by my GP that he was starting to notice signs under the surface that he thought I was actually suffering from a little bit of depression. So he put me on an anti-anxiety med. Didn't really help much at all. He sent me for counselling. That was a little bit more beneficial. But I think the big thing that assisted with that was just acknowledging him, saying, yes, there is something wrong. It is serious. And I don't have to be happy about it. It's fine for me to acknowledge that this is something that's really pissed me off. And quite rightly too, it's something that's happened to me that's out of my control, that I don't have to accept. I have to accept it to a degree because it's going to be with me for the rest of my life.
So a range of symptoms here. Really, depending on the site of lesion, that's going to determine what symptoms you get. Just like with stroke, tumors. Fairly common would be that fatigue. Autonomic function is often affected. So you'll see incontinence, sexual dysfunction, sleep abnormalities as well. Spasticity is fairly common. A lot of what you see is going to be sensory, motor, cognitive impairments. Seems like a coin flip in about half of the cases. cognitive function is intact, and in other cases you see profound memory loss. Of course, as the disease progresses, if it is a progressing version, that gray matter atrophy is going to lead to memory impairment as well. Depression is far more prevalent in MS patients, also suicide as a result of depression, because this can be fairly troubling. A fairly simple task that we take for granted, like just automatically understanding what a word means. These things become very difficult. Everything is very tiring for them because the conduction of action potentials is no longer as effortless for neurons. It's not as fast, so everything kind of slows down as far as your cognitive processing is concerned, and everything is far more costly. Neurons are going to exhaust much sooner than they would with myelination. Pain is another common complaint. He mentioned pain. The pain that we see is caused by demyelination. Now, hopefully, we all appreciate that myelin helps kind of keep our axons insulated from one another. If you answered question 1 on the exam, then you should know that. Hopefully, you told me about that. It's kind of nice. It helps us pack our axons very close to one another so we can fit a greater number of neurons in the nervous system. So when you lose that insulating sheath, as we see here, then as the action potential is conducted down, we reinsert ion channels so we can continue to propagate the action potential, albeit a little slower and a little more costly. That efflux of potassium that occurs in the action potential is going to stimulate nearby neurons. These nearby unmyelinated axons, and guess which axons are unmyelinated? Nociceptive axons, those involved with pain, exactly. They're also very, very small, and that matters. E equals IR. Ohm's law. It's true in this case, just like everywhere else. The smaller it is, the greater the resistance. So with a given current of potassium, you're going to get a greater potential buildup. So you see a greater degree of depolarization in the small axons. If you don't like to think about Ohm's law, that's fine. Just think about the concentration of potassium. If it's in a smaller axon, it's going to be more concentrated, so you have relatively more positive charge. As that potassium flows in, that can initiate an action potential. So now the non-painful sensation that was getting conducted up that demyelinated A beta fiber stimulates a C fiber. This creates the sensation of pain where it should not be. We've lost our insulation here, so we get what we call olfactic transmission. Now we're leaking out potassium where we shouldn't have. And that potassium is going to depolarize nearby axons that are small and unmyelinated. And those are pain-sensing axons. That pain, along with the spasticity, is going to contribute to fragmented sleep. This is going to lower the quality of life, of course. We all need our sleep. Do we have any questions? Well, Lord knows I do. Make sure you can answer these, and then we'll move ahead. Thanks. Okay. Well, yeah. Good question. Oh, don't get ahead of yourself now. Hold it. I'm sure you read all this. And so floating around back there. But it's probably not in all cases. Alrighty. We got quite a few risk factors associated with MS. Britta, where are we at? Hi. Can you tell me some of the risk factors for MS? Which ones are environmental? Which ones are genetic?
So your vitamin D deficiency is more environmental. I suppose technically it could
Okay.
be genetic to an extent.
Yeah.
Your mom,
Yeah. So why do you say that it could be genetic to some extent?
because it's like you're getting, I guess your mom's getting vitamin D while you're in her womb. So
Oh, okay. I thought we were going to bring up differences in skin color and how they absorb sunlight. Okay.
that too.
So how is it environmental?
Because of the sun.
Oh, hey, there we go. So do we get constant sunlight all year round? Okay, that's just a softball question. Just knock it out of the park.
Wish I did, but no.
No, we don't, right? Not unless you live at the equator. All right. So if your mother's carrying you in the winter months, less sun, vitamin D. What does vitamin D have to do with this? Were you here for my question answering rant beforehand?
Your T cells are more reactive.
Fantastic. We'll leave it there and we will get back to those. That's great. I think we're okay on that. How about the male to female ratio, just so we have that tucked under our cap here?
It's more common in females.
Okay, good. All right. So there's a variety of motor and sensory abnormalities. Let's just name a few, so we have those. You know, I should remember this. Leah or Lee? Which one? Leah. Okay. I'm going to get it right. Probably by the time your next semester ends, I'll have it. Okay, Leah.
Yeah.
Just rattle off a few.
Okay, so you get sensory loss, optic neuritis, weakness, paresthesia, diplopia, and ataxia.
Okay, fantastic. Do we need to translate any of those words?
Is diplopia double vision?
Yeah. So, are there any other abnormalities besides those little bullet points? One that might relate to this. Factory transmission. What's another common symptom in MS?
Are you talking like autonomic dysfunction or still?
Well, it's kind of. Well, it's not motor or autonomic. Yeah, it's sensory. Yeah, exactly. Okay. Yeah. Okay. All right. We'll get through that little part. Okay, and that brings me very awkwardly to my next question. What is a factor transmission? The suspense is killing me. Sarah. Is there more than one Sarah? Okay.
It's just me.
The one and only. Well, tell me, what is a factor transmission?
That's when the oligodendrocytes are being attacked and the myelination is gone.
Okay.
So then they start leaking out potassium,
What leaks out potassium?
the axon.
Okay, great.
And that goes to the really small unmyelinated fibers, which are the nociceptive fibers. And then they get overwhelmed with potassium and they start firing and then you get pain.
Very good. All right, so non-painful stimuli lead to the sensation, or the perception of pain. Yes.
I was gonna ask you to repeat that because I could not hear a word she said.
Okay. So yeah, it's where we have demyelination. Normally we shouldn't move any ions across this, what used to be an internode, but it's no longer an internode. Now it's a big ass node. And we have a bunch of ion channels filling that up. We're going to allow sodium to come in. We're going to also export potassium. So that's what happens when the action potential moves along the axon. When that potassium leaves, just like we've talked about in stroke and I think tumors as well, that potassium that exits during the action potential, if we have a buildup of extracellular potassium, that's going to cause depolarization. The axons that are going to be most sensitive to this are the smallest ones, because they're going to be easier to fill up. You can think about it that way, that's all right. And they don't have myelin. If they had a myelin sheath, that potassium wouldn't be able to get in. So only the small unmyelinated axons, which happen to be nociceptive, get stimulated. We'll touch on this later when we talk about trigeminal neuralgia. It's going to be the same story. Do we need to go over any of this? Yes.
So this might be a stupid question, but whenever it demyelinates, is it at just one internode and then eventually it could become all of the internodes on the axon that becomes?
Yes. So it's going to be very focal demyelination. As you have a greater number of oligodendrocytes die off, then you'll have a greater number of internodes that are lost. Good question. Yeah.
How is that focal point determined?
Which oligodendrocyte dies. So each oligodendrocyte is going to wrap around a few different axons, but only one internode. So they don't myelinate the entire length. They only hit that, 100 to 500 micron distance that they wrap around. They'll hit multiple axons, but only one segment of a single axon. If that oligodendrocyte is targeted and destroyed, anything that is myelinated is, of course, unmyelinated. Now, what destroys our oligodendrocytes? I'd say for the most part, this is caused by an autoimmune response. I think that's fairly well established. There's more to it than just that. So in MS, we see a permeabilization of the blood-brain barrier. Serum proteins are able to leak into the brain. Not only that, our lymphocytes are able to infiltrate as well. Under normal conditions, we shouldn't have infiltration of immune cells into our nervous system. This only happens if we have an infection or anything that's causing a leakage of the blood-brain barrier. So inflammation. And we do see evidence of increased inflammation in MS patients. We'll get to that in a second. Now, normally, our immune system should be able to recognize our own cells as self. When it does, it shouldn't destroy them. There are a variety of diseases where this self-recognition is impaired. Different tissues can be targeted. It could be connective tissues in the case of arthritis. Yes, I don't know a lot about that. That's outside the nervous system, but I think that's the case. Don't quote me on that. In this case, too bad I'm recording this. Damn. In this case, we're targeting oligodendrocytes. The immune system is targeting oligodendrocytes. Oh no. When they target this, when they recognize the oligodendrocyte as not self, they're going to destroy it. This shouldn't be here. There are mutations in the, let's see, and what is that? Leukocyte histocompatibility antigen, I think, LHA. It's what we call our major histocompatibility complex. Same thing. Mutations in the major histocompatibility complex underlie some cases of multiple sclerosis. So if you have mutations in some of these self-antigens that you present to your immune system to say, don't kill me, if those are mutated, they don't look like self anymore. And that appears to be the case in MS. There's a lot going on besides that, as this cartoon suggests. It takes a village. In the end, it leads to the destruction of oligodendrocytes. It could be the selective targeting of oligodendrocytes by our immune cells. That's what this portion of the cartoon is telling us here. It could also be a pronounced inflammatory response that leads to the destruction of oligodendrocytes. Either way, oligodendrocytes get killed off. And it seems to be because of autoimmune regulation. This seems to be the main thing going on. But that's not all there is to it. When we lose our myelinating glia, there will be segments of the axon that are unmyelinated, and that's what we're looking at here. It's a beautiful picture. Green is showing you neuron and axon, and the red is showing you myelin. And here you can see individual portions of the axon no longer myelinated. This is abnormal. Our internode should be incredibly small, 2 microns. I say node, our nodes should be 2 microns. Internode's much longer, at least 100 times that size. So here we have exposed axon. If we're going to continue to propagate an action potential through this demyelinated region, we have to reinsert ion channels. This is still true. See Lecture 1. When we insert a greater number of ion channels into the axon, we move more ions across the membrane. The more ions we move, the more ions we have to pump out. That's not free. So by demyelinating your axon, you create additional sites of ion flux, additional areas that are going to increase the amount of ATP that you have to create. Does that make sense? We'll probably say that again in this class. That's going to lead to oxidative stress. What I mean by that is the production of free radicals. They're also called reactive oxygen species because they're going to oxidize components of the cell. When they do that, they damage lipids, proteins, DNA. Hopefully they get neutralized before doing that, but that's not always the case. And as you increase your ATP synthesis, you increase your production of free radicals, you increase your likelihood of damaging cellular components. Nothing new here. It's the same song and dance. We're not going to go through that. But that's not all that's occurring in MS. There also appears to be glutamate toxicity as well. Same story. Nothing new here as well. So if you understand glutamate toxicity, great. You can zone out for a little bit. If not, I'll tell you about it again. All right, we'll start on the bottom here. This is evidence for inflammation in MS patients. TNF alpha, do we remember this? Lecture 2, it's back. TNF alpha, this is going to stimulate an inflammatory response. That's going to decrease the permeability of the blood-brain barrier, allow infiltration of lymphocytes that are going to target myelinating glia. So this tells you we have an inflammatory state in primary progressive or the relapsing remitting forms of MS that are more common. What we also see is elevated levels of glutamate. Now, both of these are far more specific to the more common relapsing remitting MS. The primary progressive MS seems to have some other mechanism. That's probably just the autoimmune target. But in the relapsing remitting MS, we see elevated levels of glutamate. Now, why might that be the case? It could have everything to do with this. Increased levels of TNF alpha, increased blood-brain barrier permeability, the leakage. Did I mention it? No. Well, the leakage of plasma proteins that lead to reactive gliosis. Reactive gliosis impairs the function of those glia that respond. For example, astrocytes no longer buffer potassium. I'm pretty sure I talked about this in our cancer lectures. Go back to that if you need to review it. They're also going to take up less glutamate, which might explain this elevated level of glutamate that we see in MS patients. It could also be the case that those infiltrating lymphocytes, they also release glutamate, it turns out. So they're going to increase glutamate levels as well. It could be because of those glial scars that we see, that reactive gliosis, and it could also be because of the infiltration of lymphocytes. Either way, we have an elevated level of glutamate. Elevated levels of glutamate are toxic to neurons. They're also toxic to oligodendrocytes. They also have glutamate receptors. It probably helps them find where neurons are, because how's a glia going to know where a neuron is? They have to have neurotransmitter receptors. And they happen to have glutamate receptors. Gal-C positive cells, those are just oligodendrocytes. So replace this with oligodendrocytes. As they hit them with higher doses of AMPA, which is a ligand that's going to stimulate AMPA receptors, you see the same thing with glutamate. The number of surviving cells drops. In other words, glutamate is toxic to oligodendrocytes. If you block AMPA receptors, we see reduced toxicity. No surprise there. So here it is, normal condition. Hit them with some AMPA, it's toxic. Block AMPA receptors, not as toxic. That makes sense. AMPA receptors, at least in oligodendrocytes, are very much calcium permeable. It's not always the case in neurons, but it is true in oligodendrocytes. Excessive levels of glutamate are going to lead to glutamate excitotoxicity. It's also going to lead to the death of myelinating glia. That's what we see here. So that demyelination could be from an immune response, but it doesn't seem to be in all cases. For whatever reason, that elevated level of pro-inflammatory cytokines increases blood-brain barrier permeability, allows the infiltration of your lymphocytes. They release glutamate. We see higher glutamate levels, and glutamate happens to be quite toxic to oligodendrocytes and neurons too. This explains the demyelination. It also explains the gray matter atrophy that we see as well. The progression of this disease is variable. Most cases are what we call relapsing remitting, meaning there will be symptom onset and then remission. So the symptoms will come on, they'll go away. In some cases, there's no progression beyond this. There are waves of motor and sensory abnormalities and then a return to normal. Here's our demyelination, remyelination. Demyelination, remyelination. So as we restore the communicative properties of our neurons, we restore function. Yeah?
So is this one caused by our glutamate inflammatory and not by the autoimmune?
Looks a lot like it. There could still be some sort of autoimmune dysfunction going on as well, but this certainly plays a role here. Not so much in the primary progressive MS. Oops. Now, about 2% of these relapsing remitting cases are going to progress each year to the secondary progressive MS. So they have this period here of relapsing remitting, and then symptoms never go away completely. We see this progression over time of worsening symptoms. We still get attacks. We still get waves of symptom onset and offset. But the underlying level of function worsens over time. This suggests death of neurons. When our baseline levels become worse, that's telling you you can't fix the problem anymore, and you can't fix the loss of neurons. So we still see demyelination, remyelination, but we're also seeing an underlying tone of neurodegeneration. In most cases, neurodegeneration follows that demyelination, remyelination. Yeah.
So in relapsing remitting MS, does the whole wave and everything go away? Or are they still having the waves, but symptoms will always go on in the off period?
Oh. In some cases, you can have no further waves, no further attacks.
So it's like they never had MS.
Yeah, you can have very brief periods, but in most cases, this is going to continue on.
Which
You
is
can-
the symptoms in between.
You can reduce the number of attacks, though, with the treatments that we're going to get to. So you can actually modify the course of this disease. That is the good news here. We actually have good news, believe it or not. Yeah.
Is the reason that like the neurodegeneration occurs like or after the demyelination because like they no longer have that protection?
Yes. So they have to generate more ATP, and there's also that evidence of glutamate excitotoxicity.
Okay.
Both of those will kill a neuron.
Okay.
Take your pick. It's probably a mixture of the two. Except in this case. In the primary progressive MS, where we just see progression from the onset. Symptoms come on and they continually get worse. Yeah, we'll have a couple of waves. That's totally possible. But there's this underlying progression that's fairly constant. This suggests to us that we see neurodegeneration from the start. We're creating a problem that we can't fix. And then we have our progressive relapsing, where we see more pronounced spikes. Same underlying progression of neurodegeneration here, just with some more spikes. So really we have two things going on that we need to think about. There's the attacks, and then there's the progression. The progression can come on at the start. We could have attacks that last the rest of our life. We could have attacks that lead up to some point where we have progression, or we could have progression and then attacks afterward. So it's just mixing and matching these two underlying courses of symptom onset. Attacks or progression, constant progression. All of the treatments that are disease modifying interfere with immune function. They suppress the immune response in the central nervous system. That's their commonality. There are several different disease-modifying treatments. I bolded the first-line treatments. They've been around for longer. They have better tolerance in patients. Some of these antibodies can create widespread issues. I've listed the side effects in my notes. But these can actually decrease your likelihood of progressing, of going from this relapsing, remitting, where you can return to the progressive forms of MS. One of those first-line therapies would be interferons, which act at the blood-brain barrier to tighten it up. So they decrease blood-brain barrier permeability. They help keep the immune cells out by acting at the blood-brain barrier. They also appear to regulate the expression of pro- and anti-inflammatory cytokines. So what they do is suppress the pro-inflammatory response that we see in MS patients, remember that elevated TNF-alpha, and they promote the expression of anti-inflammatory cytokines. This is also going to help keep the blood-brain barrier permeability low. The other first-line therapy is this, I don't know, litirum or acetate probably. It's a collection of very short peptides that are put together randomly from 4 different amino acids. And what it does is kind of mimic myelin proteins to some degree. So it's a random collection of polypeptides that interferes with recognition of myelin by immune cells. This will bind to T cells and prevent them from targeting myelinating glia. It also affects anti-inflammatory expression, just like our interferons. And it also stimulates the release of neurotrophic factors. Those sound wonderful, and they are. Neurotrophic factors, factor just means thing, neurotrophic. These promote the survival of neurons. So treatment actually causes the nervous system to promote neuron survival. It suppresses apoptosis in neurons. So you are less likely then to progress. You're less likely to have neurodegeneration because that is what underlies the irreversible progression. There are other therapeutic agents in case these first lines aren't effective. They do pretty much the same thing. They're going to prevent an immune response in the CNS. Some are going to prevent the proliferation of lymphocytes. This can be a bad thing because you get systemic decrease in immune function. And then others are going to prevent entry into the nervous system. Some will sequester our lymphocytes to lymph tissues, and then others are going to bind to proteins necessary for crossing the blood-brain barrier. Either way, they accomplish the same task: prevent an immune response in the nervous system, because that appears to underlie the demyelination and progression that we see in MS. And here we can see a reduced likelihood of progressing from that relapsing remitting to your secondary progressive MS. And if you can prevent that neurodegeneration, then you prevent lifelong dysfunction. It's pretty nice. I can tell you're all excited. Do we have any questions? Well, I have more questions than I have time. So we're going to have to talk about this next week. Is that all right? Will we survive? All right. I'll try to be strong. See you next week. It's not as yeah. Noel, how you doing? Huh?